Hello guys, good evening. Are you ready for this session? Okay, so let me just go back to the doubts. So I'll go from down. Okay, so there's a question. Are people around so that you don't miss anything? Okay, so the first question that I'm going to discuss is a patient developed proptosis and diplopia of 2 months duration following injury. On examination, there is chemosis. Hi, good evening. There's chemosis, conjunctival redness, and external ocular nerve palsy. Investigation of choices. First of all, that's a very ridiculous question. External ocular nerve palsy. Okay, so let's just say there's an extraocular motility defect or there's a nerve palsy. Okay. Now, what is the diagnosis? First of all, see, the question actually asks what is the investigation of choice. So for that, you should know what is the diagnosis that you're dealing with so that you go for the investigation of choice. All right. So so what are the pertinent points? So whenever you read a clinical stem, you should understand to come to the diagnosis. So let's say I have a patient sitting in front of me who comes and gives me this history, or he comes, the eyeball is protruding, and he says I have diplopia for 2 months, and on history he says there was a trauma, okay, 2 months before. And when I'm examining, I also see chemosis. What is chemosis? Conjunctival edema, okay, that is chemosis. And then there's conjunctival redness, which is congestion, and there is a nerve palsy. Okay, so all these are there. So where do you localize this lesion to? So when you have proptosis and you have a nerve palsy, you kind of have to think whether it is because of something in the orbit per se. Okay, because there can be crowding in the orbit which is leading to muscles not working, or restriction, mechanical restriction to the muscles could possible if you have some orbital lesions, or you can have something in the orbital apex, or you can have in the just behind the apex you have just in front of the apex you have this superior orbital fissure. So whether it's the superior orbital fissure, or it can be it has passed beyond into the cavernous sinus, so you can localize to any of these. Now the clinching point here is the trauma. Okay, so following trauma, what happens is there can be a caroticocavernous fistula formation, CCF formation. Okay, so you should understand because there is chemosis. Okay, now why chemosis? When you have a caroticocavernous fistula, the venous drainage is kind of impaired because the arterial pressure is transmitted to the venous sinuses. So the orbital blood which is going into the cavernous sinus will be impaired. The venous blood will be impaired because the pressure gradient is reversed. Okay, so the pressure gradient is reversed, so definitely the blood flow is not there, so the blood is going to accumulate here. So what you will see as chemosis and redness. Okay, so there will be conjunctival edema and redness. All right, so there is a CCF. Now what are the causes of CCF? In most common cause is atherosclerosis, because it is very commonly seen in elderly. So in elderly, it is spontaneous CCF you get with atherosclerosis. Okay, and in young patients, the most common cause is a blunt trauma. Okay, a head trauma causing a CCF. Now here they've actually not mentioned the patient. They've not mentioned the patient's age, but given the combination of symptoms and signs, it should be CCF. So now let's see what is the investigation of choice. Let's see the options. So one is MRI, number 2 is contrast enhanced CT, number 3 is MR angiography, number 4 is intraarterial digital subtraction angiography. Okay, so nowadays this DSA, what do you call that, digital subtraction angiography, that is the investigation of choice. Okay, that is the investigation of choice because CCF is your diagnosis, caroticocavernous fistula. All right, now actually they could have given you even more details. If they had given you something like pulsatile proptosis, probably it would have struck you immediately that we are talking about CCF, because they have just stopped with saying it's proptosis, you're finding it a little difficult. Okay, but if they've given you pulsatile proptosis and there is thrill on palpation, I'm sure this would have been a cakewalk. Okay, this question would have been a cakewalk. So any doubts in this particular question? that we've discussed. So now you know how CCF presents with. All right. Okay. Now, the next question is a 75-year-old patient who was a known case of diabetes mellitus for the past 25 years presented with sudden painless loss of vision. On fundus examination, flame-shaped hemorrhages were seen in retina. Probable diagnosis. Okay, actually here, none of the options that are given are right. Okay, so I think whoever posted this on my Telegram group, see, a 75-year-old patient, you have a diabetes mellitus for the past 25 years. There's a sudden painless loss of vision. Okay, now it's kind of a little dicey. Okay, now they have told you there's a sudden painless loss of vision, and then they've told you on fundus examination there's flame shaped hemorrhages. Okay, they've not talked about microaneurysm, they've not talked about dot blot hemorrhages, they've not talked about anything else, and then they've given you option and probable diagnosis. So first option is CRAO. Now in CRAO, retinal artery occlusion, we do not get flame shaped hemorrhages. Okay, and diabetes as such is not the most common or the most important risk factor for CRAO. So I wouldn't entertain CRAO as a diagnosis. And there's no cherry red spot, there's no talk of milky white retinal edema. So probably not. Okay, probably not. Let's come back to it. We don't know. Now B, retinal detachment. Now retinal detachment, going by the presenting symptom, sudden painless loss of vision in a diabetic, yes, can happen. But they've, on fundus examination, they've not told you anything about a retinal detachment. They've only told you about flame shaped hemorrhages. So I really would not like to entertain this diagnosis of B. Okay, because see, everything should correlate. Your sign and symptom and your examination, everything should correlate. So right now I do not want to entertain that diagnosis. And then C, proliferative retinopathy. See, proliferative retinopathy, yes, it can cause. How? Because proliferative retinopathy by itself, no, but when the new vessels, they rupture, they will cause vitreous hemorrhage, which is very, very likely. But again, if you have vitreous hemorrhage, you can't see the fundus, and they would definitely say there is a hazy view of the fundus, something like that would have been mentioned, which is not mentioned. So again, proliferative retinopathy, I would not like to go, because again, flame shaped hemorrhages are part of NPDR. There is nothing suggestive of PDR in my question stem. Okay, and cystoid macular edema, it will never cause a sudden painless loss of vision. So, and there's nothing suggestive of that in your clinical question. So that question itself, I would say it was kind of, not really thoughtfully framed. So you understand? So every question has to be very, very thoughtfully framed. So if at all they had given you on fundus examination, there is a there's flame shaped hemorrhage and there is a grayish retina. Okay, they've said something like a grayish retina, then I'm sure the answer would be retinal detachment, because a detached retina is no longer transparent. See, let's say this is my choroid, this is my retina. Okay, choroid is vascular. Okay, and your retina is transparent, so you see that reddish orange color of the fundus. But when my retina is detached, it is no longer, does not have the transparent character, so you get a grayish white appearance of the retina. Okay, so if they've mentioned that in the fundus, then probably I would take the answer as retinal detachment. But per se, given this combination of this cluster of however this question framed, none of the options are right. Do you understand how to go about this question? Okay, so don't get anxious if you're not able to answer such questions. It's okay, good that you brought it to my notice, but at least now you know what it is. So do you understand? So if there has been, they've said the fundus view was hazy. Okay, the fundus view was hazy, probably it's vitreous hemorrhage, because vitreous hemorrhage, yes, you will have because of the PDR, the vessels rupture and you can't see the retina through that, and it causes a sudden painless loss of vision. Okay, so this question, all right. Wait, any doubts in this question? Okay, let me go back. What was the previous doubt? Okay, this angle wala question is very simple. Okay, now what I'll do is, now let's say, do I have something to show you? Okay, let me just show you like this. Okay, let's take the E chart. Okay, now E chart, you have 3 limbs. Okay, now first, before this, let me tell you how do you look at a vision. Okay, when you record visual acuity, you write something like, let's say 6 by 60. If I'm seeing the first line, okay, I write it as 6 by 60. I mean, I'm seeing only the first line. I'm not able to read anything beyond that. So when I say 6 by 60, what does it actually mean? I'm supposed to stand, a normal person, if he stands at 60 meters distance, he can see that letter. But I have a defective vision, so I'm standing at 6-meter distance and I'm able to see only that first letter. So I'm standing at 6 meters and reading a letter which is ideally supposed to be read at 60 meters. That is why we write it as 6 by 60. Do you understand this? Now this is your visual acuity. Now what is called as MAR. Now what is MAR? Minimal angle of resolution. Okay, what is minimal angle of resolution? It is the inverse of visual acuity. So that means if I have a visual acuity of 6 by 60, I'm reading only the first line. What is my minimal angle of resolution? My minimal angle of resolution is the inverse of 6 by 60, which is 60 by 6. 60 by 6 gives me 10. So 10 minutes of an arc is my minimal angle of resolution. Now what is minimal angle of resolution? Minimal angle of resolution. Now let's take this E chart. Okay, now E is like this, correct? So E is like this. You got 3 limbs with spaces. So I got totally 5 equal areas. 1, 2, the black area, the area space 2, the other limb 3, the blank area, and this. So 1, 2, 3, 4, 5. So when I say minimum angle of resolution, it is this one portion, either the black or the blank space. Okay, so that is minimum angle of resolution. So I am able to differentiate this bar from the intervening space and the next bar and the intervening space. Okay, so when I say minimal angle of resolution is 10 minutes of an arc, this angle it makes with my eye, okay, this what it makes with my eye is 10 minutes of an arc. Do you understand? So that is minimal angle of resolution. So how much does my entire alphabet make? My entire alphabet has 5 parts. So 10, 20, 30, 40, 50. Do you understand? So how much is my entire alphabet making? 50 minutes of an arc. You understand? Guys, you get this? It's very simple. So what is the visual acuity? It's, if I'm reading only the first line, my visual acuity is 6 by 60. What is my MAR? That is only one part. That is inverse of my visual acuity, which is 60 by 6, which is 10 minutes of an arc. So the entire alphabet subtends an angle of 10, 20, 30, 40, 50. 50 minutes of an arc. Is that clear? If you know this one concept, it's going to be simple. Now let's say I have a normal vision. Normal vision means 6 by 6. So 6 by 6 means how much does the alphabet subtend? So what is my minimal angle of resolution? My minimal angle of resolution now is 6 by 6 only. Inverse of 6 by 6 is 1. Okay, so minimal angle of resolution is 1. So now 1, 2, 3, 4, 5. So my entire, excellent Vishal, that's it. So I got 5 minutes of an arc. Clear? Now let's say I'm reading the second time I chapa. So let's say I'm able to read the second letter. Now second letter you have to read it as 36 meters. We read it at 36 meters. So what's your visual acuity? 6 by 36. Now what is the minimal angle of resolution? 36 by 6, which is 6. So what is how much is the entire alphabet subtend? Come on. 6. 6 into 5? 30. Simple. That's it. Okay. So you got it. So there's no headache about this. That's all. Alright. Okay. So that was the doubt. So anything if they ask you, now you know. So even if they're going to ask you what is the minimal angle of resolution for a patient with vision 6 by 36 or 6 by 24, you know. And even if they're going to ask you the vision is 6 by 18, what is the angle subtended by the entire alphabet, you have answers. Okay. So that's the concept, and the rest are all images. Okay, retinitis pigmentosa, guys. Most common type is sporadic. Okay, it just happens just like that. Okay, so that's sporadic. But when the question they ask you most common inheritance, see, sporadic is not about inheritance at all. ऐसे ही होता है, it just happens. Okay, so when they ask about inheritance, you can never answer it as sporadic. The most common inheritance is autosomal recessive. Okay, the most common inheritance of retinitis pigmentosa is autosomal recessive. The one with the best prognosis is bad. Okay, remember that. The best prognosis BAD. Autosomal dominant has the best prognosis, and the worst prognosis is with X-linked recessive. Is that clear? Okay. Okay, somebody has asked, how does decrease in intraocular pressure increase the blood flow in the treatment of CRAO? I'll just show you one thing. Now, why do we use that in CRAO? Now, let's say this is my eyeball. Okay, we have a condition called central retinal artery occlusion, where the central retinal artery is not perfusing into the eyeball because there is a block somewhere. Now, I go on massaging this. Okay, I go on massaging my eye. Okay, with my index finger, I massage. So when I massage, I'm actually increasing the intraocular pressure. So what I do is the technique is important. That's what you do not know. See, when you're reading only from textbook and when you're taught only from textbook, there's no idea. So we ask the patient to give nice pressure and suddenly let go. So when you suddenly let go, what happens? See, when you're nicely giving it, the pressure is increased. And when you suddenly let go, the pressure suddenly drops. What happens is, have you done, I'll tell you one analog, okay? Have you seen this tap block at home? When a tap is blocked, the nulla is blocked, what do you do? I remember when I was a kid, the plumber used to do this. He used to come and, he used to put his mouth on the tap and he used to do that. And then suddenly he will leave. The moment he leaves the tap, the water will just flow in. Have you ever noticed that? Or even if you just hold the nulla, no? You hold the tap, just block it for some time, especially when there's an air block in the line. And you suddenly let go, the water will just gush down. So same way, now we are increasing the pressure and you suddenly let go. The pressure falls. So there's a pressure gradient that is established behind the eyeball where there is an occlusion of the central retinal artery and within the eyeball. So now your blood, when there's a very small block, okay, let's say a very tiny embolus which is blocking, which can be pushed off. So now the blood will just come gushing in, pushing off the embolus and resuming the circulation. That's the whole idea of this ocular massage, but it's not a foolproof method. Yes, it does work at times. You can't really guarantee, but this is the mechanism how it works. Did you understand? Okay, see, often people are very, 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 very common sense wale people. Okay, the others are images and I have to show you some images. Okay, I will take some images and then I'll explain to you. Alright, so far so good. Okay, because too long you will not watch. So it's like almost like a 20 minutes video. Now more questions. Okay, I will answer as and when. So we will take 3-4 questions at a time and we'll do it. Okay, so any doubts now, guys? Are you clear about this topic? Are you confident about this topic? Are we done? They're waiting to close. Shall we call it a day? I mean, at least now at the clinic, I'm going to call it a day. All right? Are you fine? Okay, good. Thank you, guys. Love you. Bye.